I can talk about is opportunities within the MIH space and ways to show your value proposition. And that ties into what Matt was talking about yesterday and what we've heard this morning about finding ways to help show your value proposition in the community. So that's really the lion's share of what I'm going to talk about today. So a little bit about me, my views and opinions. They're my views and opinions. They don't represent anyone else. Full disclosure, everything I have is based on Tim's information. So I stole what Tim's going to talk about later and then tossed in my own nuggets. Here's our learning objectives for today. And then I have a couple of questions. I'm going to throw these in throughout, and I hope it doesn't distract from the overall conversation. But here's my philosophy and my belief. My belief is that MIH is all about innovation. It's about finding creative ways to provide services. And so I'm going to throw in some innovation questions today and just randomly ask people to answer them. So I'm going to start back here. Where can your organizations rank with convention?
I don't know. It's already doing it.
So it's still breaking with convention. Where would you like to go? What would you like to see your organization do? If the sky was the limit, money was no option.
Oh, geez. Yeah, I'd love to provide a lot more mental health services that our agencies isn't doing. That's an obvious hole in healthcare.
So I'm going to talk about some inconvenient truths here in a little bit, and I want you to remember that answer when we get into it. Okay. And then what counts that you're not counting? Dave, what counts that you guys aren't counting? Is there a measure that you guys should be measuring that you're not right now? Is there something you can think of that, man, I'd sure like to know that number, or either because I just don't have capacity or there's not a meaningful way to gather that data right now? Is there something you'd like to know that you don't know within your organization?
After this conference, all the billing metrics that we're talking about, learning how to track audit the billing company and make sure we're doing what we need to be doing.
Yeah, I think that's a sign of a good financial conference. When you walk away feeling willfully inadequate in your knowledge, skills, and abilities, like that's probably a good sign, because that's what we're all here for, right? Is to find we're poking at the gaps, right? And so I think that's a very honest answer, and it's not an easy answer to give in a room full of peers, is it?
No.
But when you want to be innovative, you have to expose yourself, and you have to make yourself vulnerable. And as an industry, we're really bad at doing that generally, aren't we? All right, so here's some inconvenience truths. And the first one goes right to what we were talking about, right? The services that are most likely to generate revenue for you are the ones your people are least likely to want to do. Why is that? Because nobody wants to do it. If they did, it would be getting done. It's hard. It's gritty. It's dirty. And sometimes it feels unrewarding. That's why those gaps exist. If it was something fluffy and easy to do, like rescue puppies, right? Or treat kids with cancer, like that stuff's getting done because it fills our cup easily, right? These things in the MIH space often are the harder things to do, because honestly, there aren't a lot of people that want to do them. So, and then perfect is the enemy of implementation. I can't tell you how many times I've heard, I want to get this program up and going. I want to do this thing, right? But we're building it, we're building it, and we're just not ready to pull the trigger yet. But you got a few more things we have to work out. We got to work this out. We got to work that out. And here's the deal. We did that time and time again. We delayed before we rolled out new programs, only to roll out new programs. And guess what? They were still oh, I almost did it. there is still a crap show, right? Because you don't know what you don't know. You gotta get it out there. You got to put it in service. You got to test it. You got to try it. You got to let it break. Take that good idea, do the best you can with your team to tease out what you think is going to, and then get it in service, get it on the road, get it working, right? We do that with new vehicles, don't we? We get them out there and we run them. We know they're going to break. We know there's going to be little things that come up. We know that electrical board is going to go out and it's going to have to sit in the garage for 6 weeks while they send us another one until the tech can get there and reinstall it, right? Right. But you gotta get it out there. You gotta break it to fix it. So don't let perfect be the enemy of implementation. And then the value of MIH is found in innovative systems efficiency, right? The healthcare system is broken. Who here in this room has struggled on their own, not for the patient, on their own, to figure out a bill that they got, or try and make an appointment with a specialist, or try and get care for a kid in an area in a specialty? Who here's had that trouble in the last, let's say, 3 years? Yeah, look at that. Almost every single one of us. And have you ever seen a charge master? The book that the hospital keeps, that's so big now that it has to sit on like terabytes of data that tells you what they'll pay based on who you are and who your payer is. Right? That thing is confusing. It's so confusing that very few hospitals actually know what's in their charge master. Our healthcare system is incredibly complicated, and the value lies in being the easy button, or at least appearing to be the easy button. In the person that comes in and says, you know what? I'm going to make your problem my problem, and we're here, we're in this together, right? I'm going to create a relationship here, and we're in this together until we figure it out. Because you shouldn't have to go through this alone. But a lot of people do. Loneliness and isolation is the leading cause of several diseases in the United States today. It's the leading cause of death from heart failure, leading cause of diabetes, hypertension, right? And exacerbation. I'm not leading cause, but it certainly significantly increases the rates of diabetes and hypertension, depression, anxiety, suicidality, right? And so there's a lot of people, especially in areas like ours. Turns out in Colorado, people move to 200-acre parcels. Generally speaking, it's because they're a little bit prickly, right? Or they just don't really like people. Or maybe they like people, but they don't like large doses of people. And so they move themselves out to these isolated areas for a reason. And some of the very same things that they move out there for make it more difficult for them to access care. And now they put themselves in an area where there's very little care. They put themselves in a healthcare desert. I'm not telling anybody in this room stuff they don't already know. But when you do your community needs assessment, look for those opportunities. Are those the easiest people in the world to work with? Are those the ones that make your crews come back at the end of the day, pulling out their hair, swearing, you know what, I'm going to go be a taxidermist because I never, ever want to come across this person again, right? But those are the people who most need our help. And those are the people that we bring the most value to the healthcare system in making those connections. Data collection is the yellow brick road to sustainability. Erin, you're our hero. You really are. Day in and day out, she gathers the data. She makes connections with community partners. She went to the coroners and said, hey, look, we're doing this data set and we're missing your piece of data. Help us, bring that data to us. You know what they said? Absolutely. We want to reduce suicide rates as well. Let's do it. Let's partner. And taking that data and combining it with the dispatch data and mixing it with our data and mixing it with the state's behavioral health data and crisis data, she is painting a picture and I'm not even kidding, this is a term I hear on a regular basis when I share her data. She is painting a picture that's not happening anywhere else in the state and very few places in the country. That kind of data generates the value that we're going to talk about today. Does that make sense? And program success is expressed in programs' well-defined value propositions. And all these other truths help us get to that value proposition. All right, the inconvenient economic truth of MIH and EMS specifically, the traditional ambulance model. We've been talking about this all week, and everybody in this room already knows all this. But I'm going to say it again because, well, you know, maybe there's one person in here who doesn't. We have a perverse incentive structure, don't we? Only compensated for transporting, using the most expensive form of transport to the most expensive destination. And then the talking heads that pass the policies and the laws, the talking heads that do that, then go, they have the audacity to stand in front of a TV, in front of a camera and go, well, we just don't understand why healthcare costs are so high. Right? And then they blame the other side. There's no outcome-based risk in the traditional model, right? We're not held accountable for patient outcomes, are we? Not from an incentive standpoint. I mean, if we kill somebody, we might get sued. But truthfully, more often than not, if we make them happy, we'll probably get away with it. Right? Let's be honest. Right? It's not the right thing, but it's the true thing. We are compensated the same, regardless of whether we're improving patient outcomes or we're not. All we have to do is load patient up at location A and transport them to location B. As long as location B is sanctioned by the gods as a place that we're allowed to take those patients, right? Then we get paid, regardless of whether or not it's the right thing for the patient. Right? Yeah, that sucks. That sucks. But it's the truth. And it's the truth because there's not enough of us in this room that are actively pushing back against it harder. We're the content experts. We're the ones that know that what we're doing isn't right 30 to 50% of the time. But it's hard to be the one that upsets the apple cart. Because let's be honest, the risk of that is they'll say, well, maybe we should dig in harder on the ones that you actually do transport. And if we find out that those patients didn't have medical necessity in every particular aspect, we'll just take that money back from you. Right? It's that, again, that inconvenient truth, that uncomfortable truth. But the right thing to do to the patient is to make sure the new 5 patient rights are met. That the right patient gets the right care at the right location for the right cost with the right outcomes. And that's not always an ambulance ride. And when we do that because the compensation structure is damaged. We do that, we're allowing the financial structure to wag the dogs, aren't we? Yeah. That the ambulance market often operates in an irrational manner. So everything I just said is true, but then there's nomadic outliers. And I'm talking about individual nomadic outliers within organizations, and I'm talking about organizational nomadic outliers. Man, anybody here used to be management or is management with AMR? Yeah, I loved AMR. I worked with them for 15 years. They put food on my table. I was very blessed. I also frustrated them every single day because I was that person that spent 3 to 4 times more time on scene than anybody else. Why was I doing that? Was I trying to piss off the dispatchers? Was that my goal in life? No, I actually liked them for the most part. What was I doing? You know, you were there. Yeah,
Patient care.
I was making a connection with my patient. Right now, if they needed to go, we went. Right? When it was time to go, if time was the answer, and that's 8% of the time that's the case. The other 92% of the time, I was trying to understand what that client actually needed. And I was trying to get them set up with the services, because the definition of insanity is doing the same thing over and over and over again and expecting different results. But we did that as an industry. Well, I picked Sally up last week for her toe fungus, and I took her to the hospital because, her toe fungus was irritating her gout. And so I took her to the hospital, and you know what the hospital said? By the time I was done typing my report, she was walking out, and the hospital said, go follow up with your primary care doc. But the truth is, she doesn't have a primary care provider. It's the number one reason people don't have access to care: lack of a primary care provider. What's the number 2 reason people don't have access to care? They don't have a health care, they don't have insurance, right? They don't have a payer. Those 2 things, just by taking time to address those 2 things, you can reduce access to care issues by 80%. Do we have the ability to do that? Do we have the ability to help somebody find a doctor? Can't we just go to a website and say, hey, here's a list of doctors in your area. What's your insurance? Here's a list of doctors in your area that take your insurance. You know what? Why don't I help you call that provider right now? Because that might be overwhelming for them, but it shouldn't be overwhelming for us, because we are not truck drivers. We are providers of healthcare. We are not a UPS driver. Look, UPS drivers are great. They get to wear the little brown suits. Very first uniform I ever wore was brown. It's kind of cool. But we're not delivering packages by weight. We're taking care of people. And I know everybody in this room gets that. But the people that are doing that as individual providers and as agencies, they're doing it at their own peril financially, aren't they? They're taking a financial hit because the bean counters choose not to see the value in it. That's their inconvenient truth. They talk all day long about increasing access to care, but if that's really what they cared about, they would endorse and embrace programs like this. But if the Affordable Care, not the Affordable Care Act, sorry, if the COVID taught us anything, and allowing people to stay on Medicaid taught us anything, increasing access to care in truly meaningful ways and telehealth taught us anything, increasing access to care in truly successful and meaningful ways is expensive. And they don't really want that because they can't afford it. It sounds really good in a talking point, and it feels really good when they're patting each other on the back about wanting to do it. But when it comes to actually creating policy to do it, it's expensive and it's hard. Is that fair? Is that fair to say? Am I wrong? Am I wrong? So when we do treatment in place, when we do transport to alternative destination, they don't pay us, even though there is a ton of evidence. You guys sat here yesterday and saw it. There's a ton of evidence to show that it's successful. Even when the program is intentionally set up to fail, and I'll say that. ET3 was set up to intentionally fail from the beginning, because they knew what it would show. And they set it up to fail from day one, and I was a participant. Every day they had a different, a change, a different requirement, a different thing that wasn't discussed from the beginning, another roadblock, another barrier. And it's because it wasn't designed by the people providing the services. It wasn't designed by you and me. It was designed by other people and other aspects of healthcare that are getting gobs of money to make sure that the patients show up in their big giant palaces. I'm not saying who it is. But they have all the incentive to make sure that programs that actually reduce the number of patients that get to them to those very expensive destinations, where they get a lot more money for the care that they provide, there's a ton of incentive to make sure that a program that diverts patients away from that cuts into their nut. There's a lot of incentive, and there's a lot of them, and they're really smart, and a lot of them go to a lot of school and get a lot of initials after their name. Right? They've got the training and education to do the studies. Remember the studies we saw that said that we don't do a good job at things? How many of those studies are actually done by EMS? Like 80%. Now remember, 80% of all statistics are made up. But like 80% of all the studies that are done in our industry are done by nursing and physicians and public policy. And maybe every once in a while, you'll see one done by an EMT or a paramedic. We are letting other industries ask the questions about our industry. Guess what? They're not asking those questions to better our industry. Is this a pessimistic view? Yeah, it's a slightly pessimistic view. But here's the optimistic belief. When you take into account our volunteers, our paid staff, our fire, our public, our private, there is no one with a larger constituency than us. Not nursing, not physicians, not hospitals, not cities, not counties, no one. If we spoke with a unified voice, even E.F. Hutton would listen. Anybody remember that? Or am I the only one? All right. Next questions. How can your customers be part of the value creation?
Customers be part of the value creation. You have to get them on board, talk to them about it, see what they're looking for.
Yeah.
And see what value they need.
There's a name for that. Does anybody know what the name is when you bring people who have been patients or have had experiences and you bring them in and you get input and feedback from them on the care that you provide, and you let that actually drive the care, and you create teams of people that do that? There's a name for it. Anybody know? Because I promise you, our brothers and sisters in nursing and in physicians' work and in public policy know. Aaron, do you know?
I mean, isn't that just like market research?
In any other industry, it would be. But it's actually called using lived experiences. It's having your work guided by those with lived experiences. People who suffer with or are surviving with substance use disorder, people who are surviving with behavioral health crisis, people who are surviving with end-stage renal disease, right? These things, and you know why you don't do that? Because it's hard. Again, it's hard. It's hard to make yourself vulnerable enough to say, you know what, I'm not the expert in what you're going through. Right? We like to feel like the expert. It makes us feel good. There's no greater, honestly, there's not a greater aphrodisiac than walking into a crisis situation and having everybody silence and turn to you and look to you for the answers. That's intoxicating. Legitimately, it is. Am I wrong? Feels good, right?
Yeah.
What's that?
The end result,
Yeah.
getting somewhere. The care they needed.
It's hard to sit back and say, you know what? I don't have all the answers. I'm not the expert in what it feels like to be a veteran. I've never been to war. Thank God, I've never had anybody shoot at me. I don't know what it's like to not be able to set my anxiety level aside for weeks, months, right? That's never been my experience. How am I going to come in and be the expert in how to manage persons with a veteran's background who are experiencing substance use disorder? Why not say you're the expert in that? Let's bring you in. You give me input. What are we missing? What am I not doing that we should do? Does that make sense? And when you do that, you gain buy-in and you gain trust. You add value to what you're offering because you're offering what your customer wants. Right? Phone companies don't put a phone out there without getting the input from people who are going to use the phone. They're probably not very interested in input from the people who don't use phones. And then who uses your products in a way you never expected or anticipated? Scott?
Right now, it's the mental health system. I didn't see it coming as to how, I mean. It also was my answer that I was thinking to one of your previous questions as well, but I didn't see this coming, that it would get to such a crisis state that it would impact EMS services that much, and that we would have no choice but to get involved in that. I'm glad that we are, and I think that we're a resource to it, but I also think we're like playing whack-a-mole with pulses, and so right now in my system, that's my choice.
I think that's a great answer, right? And we know that 20 to 30% of our calls across the nation, 20 to 30% of our calls, minimum, have a behavioral health or substance use disorder component to them. Does anybody think that less than 20% of their calls have a behavioral health or substance use disorder component to them? It doesn't mean that it is a behavioral health or substance use disorder issue, but behavioral health or substance use disorder plays a role in their current condition. Is there anybody here that believes that's not true? Yeah, I think that's fair. And please, guys, challenge me. I want to be challenged here. I am comfortable enough. And if I'm wrong, call me out as a group. I'm okay with that. I really am. So the value option equation, I'll tell you, this is just kind of a fun way. I'm a nerd. This is just a fun way to quantify your value proposition. You don't have to master this. You don't have to. I don't even know if it really holds weight for anyone else. It's just how I work through it in my own head. So if you find it valuable, great. If you don't, that's okay too. Did I hedge that enough? All right. So X is always, it's the real cost of an MIH program. Okay. So before you talk about whether there's value to what you're doing, you have to have an idea of what you're doing, if that, what the actual cost is, right? What X is. How much is it going to cost me to do this? Dave back here has this fantastic saying, and I appreciate it more and more every single day, especially as I'm sitting here right now lecturing. He's like, if you're going to start a project, a home project, if you're going to do a bathroom project or put in a new tub or a new this or a new that, he's like, take the amount of time you think it's gonna take and quadruple it, right? And then take the amount of money that you think it's gonna take and double it. And I mean, it's at least that, right? It always costs more time and money than you think it is. Then when I first started building our behavioral health program, I'm like, oh yeah, 30, 40 minutes, we'll be good, right? It's average is 3 hours per call. And it's not uncommon for them to take 6 to 8 hours. Man, when I first started doing this, I would get calls. What the heck were you doing on scene for 6 hours? That's not sustainable. But it's not every time. But the client sets the timeline. And every once in a while, that is what's required. Because whenever you push the patient, you push them to do something they're not ready for, you lose them. You lose them. They're the expert in their crisis, and we're invited to be part of the team to help them find a solution. And that's true in a community. I mentioned that we came into Park County because the state asked us to come into Park County. I would have never gone into Park County if we didn't have permission from South Park Ambulance and from Guffey and from oh, I'm forgetting the other one, Pop Canyon. I reached out to all three chiefs and I said, look, the state's asked us to do this. I only want to do this until you guys are ready to start your own program, until you're ready to take over. I would never, ever, ever step in unless you gave us permission to do this. And then I asked them, what does your community need? Because they're the expert in their community. They're the ones with the lived experience of providing service in their community, right? And they had a better idea, a better grasp of what it was going to cost than I did. And I continue to do that in Park County. I remind them every day, as soon as you're ready to take over, I will help you in any way I can. We're here to support you. It's your community. We're just honored to have an opportunity to support you. And we have to go in with real understanding of what the cost is going to be and understand that it's always going to cost more than what we actually think it is. So put in that margin, we generally do 20 to 30%. So with all things being equal, so now we're going to alternative option. The alternative option is, with all things being equal, what is the cost of the next best option? So the next best option for Park County was to do nothing, because there was no one else. They turned to us. There was really no one else that was willing to do what the state was asking. And so what is the cost of doing nothing? What is the cost of the next best option? In this case, what is the cost of taking every single patient in behavioral health or substance use disorder crisis to an emergency room where they sit for 2 to 3 days? Especially when you're in a county that doesn't have an on-duty law enforcement officer after 8 p.m. They not only roll up the streets, they put them away. And by the way, their dispatch center closes. Right? Like, imagine the cost to that community. And then the quantified value. What is the quantified value of the services you're providing? Think about your stakeholders. How do they benefit from the services you provide? Financially, economically, when you do the right thing for patients and get them directed to the right level of care, there is a quantifiable value to that, isn't there? There's also a utilitarian value. Now, what I'm doing here is I'm taking economic terms, basic, simple economic terms that we all learned in Econ 1 or Econ 101, depending on where you went, right? And I'm applying it to what we're doing. Does that make sense? So utilitarian value is the non-quantifiable costs or the non-quantifiable savings of your program to stakeholders, right? What is that utilitarian value? What is the value to your community that you can't quite quantify? And sometimes you can actually look at those utilitarian values and you can try and apply a quantifiable amount to them. But sometimes you can't, and it just has to be told through story. Or through what? What's our yellow brick road? Data, right? This is how many people died from suicide before our program started. And here's how many people died since our program started. By the way, we're trending down, but when you look across the rest of the state, they're still trending up. And when you look across the rest of the country, they're still trending up. Now, I'm not saying that our program in and of itself is the answer. I don't believe that. I believe our community and our community partners have collaborated and come together in a very meaningful way. But we are one small piece of that difference. We are the symptom of a larger desire to do the right thing as a community, to ask the hard questions. And then what are the opportunity costs? So the opportunity costs. In doing this option, in going with X and paying X, what are we sacrificing? What are we not able to do? right? What would the cost of foregoing this service and not doing anything at all? Right? So alternative option is, what is the cost of doing option B instead of option A? And then opportunity cost is, what is the cost of skipping everything else and doing nothing? Right? Versus what are the costs of choosing to focus on this and skipping that other option? What are we losing out on because we're choosing to do this? Does that make sense? All right. And then here's our three equations. X, so real costs, minus AO, and that's the alternative option, right? That gives us our value over alternative. Does that make sense? Pretty straightforward. This is what it costs. This is what option A costs. This is what option B costs. Is option A or option B more? What is the value over alternative? Right? Quantifiable value plus utilitarian value gives you the TV or total value, right? So unfortunately, like we talked about, sometimes utilitarian value is hard to quantify, isn't it? So this is real direct dollars. This is real direct dollars, and then this is indirect dollars. And sometimes you can get really creative with indirect dollars, can't you? You really can. And still be truthful and still be honest and still be transparent and look at what you're saving in alternative costs. And then if you take TV and subtract the real value, total value minus real cost, sorry, then that gives you the residual value. That's the value that your program has after you cover your nut. Does that make sense? And then you ask yourself these three questions. Is my VOA a positive value? Is my RV a positive value? Is my X less than OC? Anybody confused at this point? That's, yes, sir.
So utility value is the downstream cost that you are saving. Healthcare
Yes.
costs.
Yeah, downstream costs and other things. So what I'm going to do here is, because if you're not confused at this point,
You should.
and you're smarter than me, because even I'm a little bit confused. So what I'm going to do is I'm going to take our real, remember I told you I was going to take Tim's stuff and I was just going to use his stuff because it was way easier. Well, that's what I'm going to do now. I took this weird equation, made this weird equation, and now I'm going to apply it to our stuff to see if it actually is true or if I'm just full of crap. Fair enough? Yes, sir.
So Tiny, and here's now just starting to get into this, one of the things that I see, and obviously the collaboration, getting the community partners, all that stuff, I mean, it's, you have to do it. But what I've seen your agency and Delta County agency doing for sure is getting that UV and explaining that to the stakeholders to get that buy-in. So it's not just going out and spending 3 hours on the call. It's the back end stuff that if you don't have the stakeholders on board to they see your value, you're not going to be compensated. So your program's not going to last.
Yeah. And they're not going to be on board at first, right? Because they don't trust us, because they don't understand, they don't know. We've never historically existed in this space. So why should they trust us to do this work just because we said we can? That doesn't seem very fair. We got to start small, right? With us, it started just showing up at the meetings and asking questions, trying to understand what their challenges were, where the opportunities were, doing a community needs assessment, being involved in their community needs assessment, right? Where is the problem? Where are they struggling finding solutions? And then saying, hey, you know what? This is really hard. Like what you need to get done is really hard, but I really think it aligns with our skill set. I think it aligns with our resources. And so why don't we enter into a really small project? It could be something as simple as, let's get 100 people vaccinated, right? For us, it was as simple as, look, we are not going to transport behavioral health patients that don't have a medical need in an ambulance anymore, because that's not a medical condition. And we believe that that's law enforcement's responsibility. Now, obviously it's pivoted, right? But that was our initial, but we don't want to leave you guys in a lurch. So here's what we're willing to do. we'll take these paramedics, we'll put them through specialized training. And if you pay us every single time we show up on scene in this specialized vehicle with these specialized paramedics to support this program, do it fee for service. If you do that, then we will start managing these patients in a more meaningful way. And I was shocked when both law enforcement agencies said, yeah. I said, okay, now this is the next lesson I learned. I didn't tell them how much. I made them tell me how much, right? What's it worth to you? That's a good start. Can't really do it for that. What about this? And now we're negotiating. Make sense? So that's what is the value to our stakeholders for us to do that. And they took risk, right? There was risk. There was a real risk of coming out to them and saying, we're not going to do that. They could have just as easily gone to the community and said, the ambulance is refusing to take care of patients in crisis. And now we have to take a deputy out of district every single time. They could have done that, couldn't they? But we built that relationship. We listened to them. We heard what their challenges were. We acknowledged their challenges. We made ourselves vulnerable. We told them what our problems were, right? We were brutally honest with them. And we created utilitarian value. And that gave them the ability to identify a quantifiable value for what we were willing to do for them. Does that align with what you're saying?
Yeah, I got so many other questions.
All right, so let's look at real costs. Remember, that's X, right? X is real cost. So we're going to look at our numbers, and this is not this month's data. This is last month's data. We presented this month's data yesterday to the board. So it really, I'm sorry, I'm a month behind. So year to date, as of last month, we had 17,496 hours in our MIH model, right? That's unit hour utilization. That's how many hours we put in. We run 2 24-hour-a-day community paramedics, and we run 1 40-hour-a-week community paramedic, give or take. Does that make sense? And then sometimes I can flex onto a car. I love that. I get all excited and giddy. I still love going out and running calls. And then sometimes Ryan goes out. He's my captain, and he'll go out and run calls. So year to date, 17,496 hours. And then total packed revenue. So let's actually look at total packed cost. So this is X. This is total expenses. Total expenses for this 17,496 hours was $1,025,000. You guys following me so far? That's how much it costs for us to put those vehicles on for those 17,000 hours. And then we generated $1.8 million in revenue off of those hours. Now, caveat to this, a lot of this is state funding for our mobile crisis team, and some of it is grant funding. A lot of it is also grant funding, right? But because we created value, generally utilitarian value, because we created value, we were able, through Aaron's amazing work, to justify grants to fund our projects, right? So, and some of this comes from, like I said, state funding, grant funding, and then a little bit, very little bit of it comes from transport revenue, because treatment in place and transport to alternative destinations isn't a covered benefit yet, right? So, what does that mean? Well, first of all, our cost per UHU for the community paramedics for our MIH program is $59 an hour. That's how much it costs for us to put a community paramedic on the road for every hour, $59. And out of that $59 in expense, we generate $106 in revenue from various sources. And that gives us a return of $1.80 over every dollar expended. Yes, sir.
So you put a lot of work into these numbers. How does that compare to a 911 ambulance? What's the cost that you pass for that unit hour
Dude,
utilization?
I can kiss you right now.
Okay, please don't, but that's okay. Oh, there we go. Look at that. All right, I'll shut up.
No, appreciate that. And honestly, I'm stoked because I thought half you guys had walked out right now. So thank you guys. I appreciate it. So again, the same number of hours, 17,496. And then, the cost of of running these ambulances for the same number of hours to, 2.9 million, almost $3 million, year to date. Total ambulance revenue year to date is 3.4. So let's go back. So, it costs more, we know that, right? To run the ambulance, and it generates more revenue. But the ambulance UHU is $171, and the ambulance revenue is only $194, which gives you $1.13 for every dollar expended. That's a difference of, I feel like Bob Barker. That's a difference of 67 cents or 67%. Right? So our value over alternative is 67 cents on every dollar, or 67%. Yes, sir.
Where does capital fit
Like,
in? Capital placement.
so
Goals and
yeah, so again, these are Tim's numbers, and he can answer that better than me, but I understand that this is our all-in cost. So, you can confirm that with him. This is the number he shares with the board every month. I'm sorry, I'm ignorant to that, but I do believe that this is our all-in cost. Yes, sir.
But the all-in revenue, does that include sales tax?
Yes, yes, on both sides. And that is an important caveat, is that this does include all of our grant money, all of our other funding sources that won't be there forever, which is why, but also remember, we get paid by Medicare and Medicaid for treatment in place and transport to alternative destination. We get paid by private insurance companies for treatment in place, or sorry, not for treatment. We get paid for transporting those patients, right? We get incentivized for transporting them to the most expensive destination in the most expensive means. And we don't get incentivized for doing the right thing for patients. Yes.
All right, so my question for you, which I'll apologize in advance because I love what you're doing, these questions may sound rude. But can you build that same dashboard, that same MIH dashboard that you just had up, that shows it being $1.81, with the numbers, removing that grant funding, removing the
No, of course not.
well, but build it without those to show
Oh,
how unsustainable it is, because part of the value of data is storytelling. And it's a very powerful story to be able to say, this, with this unsustainable funding model today, generates $1.81. Without this unsustainable funding, if we look at what this is gonna look like in 5, 10, 20 years, whenever it dries up, you know, we're out
Yeah,
at like negative 85 cents on the dollar, right? Like, there becomes a value statement just in the story itself. Just curious if you-
no, I don't think that's being a jerk. I appreciate that. I appreciate that feedback, because that should be in here. You're right. And here's what I promise you. I will go and find that, and I will email it out to Kim and ask him to share it with everybody. Because you know what, that is a very good point. And then the next time I get an opportunity to do this presentation, I will add that. I think that's brilliant.
Can I ask that? Grant County has the highest non-medical death rate in the state of Colorado. Right? We have the highest suicide by, per capita in the state of Colorado. It keeps me up at night. It worries me every day. But MIH right now, based on my cursory understanding, is gonna bankrupt my department. And so trying to figure out the storytelling and funding that's necessary. I want residents in my community to stop dying, but I have to figure out how to pay for it.
And your community partners owe you more. That's what I would say. They need to believe in you and trust in you. To have a solution that will help bring resolution. Continue having the conversations with them, talk to them about other programs, and say, look, if we can find the funding together, I can be the value option in your community. I can. Here's what I can do. Trust me. So, yes.
So Austin, we're starting this MIH program and we have no budget for it, right? We're gonna lean on Kirby and Ruben and Brandon and Tiny and to try to look at that. But what your question asked, I think just looking at the numbers, They wouldn't have a program if they didn't have the grants and they didn't have the state money.
Well, that's the point to me, that's the chess move, right, is to try to figure out.
Can I tell you, we did have a program before we had the money. And that's the other inconvenient truth that I didn't talk about, is you gotta have skin in the game from the beginning. If you don't believe in yourself, no one else is going
I
to.
don't know what it's, I mean, I've never been.
I believe in you. I do, genuinely, I believe in because you have the passion for it, seriously, and you have the passion for it. Yep.
So, so with Colorado Springs Fire, you're absolutely correct. I started with a very specific grant that stood up to CARES through the state, through data and through story and through your intangible benefit becomes the value. And then through that, you apply for another grant, you're awarded another grant, stood up another division of that. Through that, put those two together, this is the population we're serving, apply for another grant, get another grant. They now have 9 divisions stood up. They're starting another with format, grant funded. And they've been able to transition 2 of those that were solely grant funded over to general fund now, demonstrating the value. But we had to exercise grants in order to get there. There is no funding for mental health without grant current. Hopefully legislation will start catching up. It just takes time.
Can I build on that?
Yeah.
I'm a taxpayer in your service area. And if any of those programs went away today, I would be the one standing on the top of the roof bitching and complaining and saying, this is not okay. This community needs these services because I know it saves me money. I know it saves me money by working with the homeless population. I'm sorry, the unhoused population. I know it saves me money working with our folks that are in substance use disorder crisis or behavioral health crisis, right? But we had to, you put your own money in to begin with, not just grant money. You guys put your own money in too. And we put our own money in the beginning. And to the tune of, I think it was several $100,000 over the first couple of years. And it was tough, and we were getting dangerously close to it going away. But when the community heard about that, we became the value option. There was no better option out there. And I promise you, our community they would not stand for us going away. They won't. They won't stand for us disappearing. Now, pride always comes before it falls. I get nervous saying that, but no, I do believe that they would be up in arms if we went away, just like I would be in the city of Colorado Springs if they would. So, all right, next set of questions. Ready? How will the business landscape change in the next 5 years? I'm going to ask you.
We're done being a trucking company. We're gonna start being reimbursed like all that.
You gotta repeat that.
So the question was, how will the business landscape change in the next 5 years? And Brandon Daruna with Eagle County said they are done being a trucking company and
Hopefully, we're gonna see legislation that's gonna change our reimbursement model, one that influence healthcare.
they are not jumping on board. They're leading the way with changing legislation to get the work that we do paid for. Is that a fair? Yeah.
It's gonna take care of it.
There you go. And then AI is going to rule everything.
Kind of, yeah.
So I'm gonna put everybody on the spot right now. Who is willing to step up and help change legislation so that we can start getting paid for the value that we're already showing? That means who's gonna be there at the table in Denver and in DC as we push these things, because we know they're coming to fruition. We're this close. Who's gonna reach out to Medicaid and say, why aren't you paying for that, Big Puff? Right? Who's gonna show up to where else? CMS, yes, and HHS, and say, you know what? You've been riding our coattails for free. You've been getting the milk for free for way too long. Way too long. We've been putting all the skin in the game and you haven't been putting in enough. It's time because we will save you money. We're trying to save you.
So, I mean, my question and challenge that, will not be different.
No.
Look, know that shit rolls downhill. And we've been at the bottom of the hill for the last 55 years.
Getting splatted every day.
Well, we are the safety net, right? We see that, that's the entire IFT thing. This regionalization of health systems in Colorado has disproportionately affected EMS, especially in our rural communities, because we're at the bottom of the hill. We keep getting shit on. Now, I don't want to be at the bottom of the hill anymore, but the problem is somebody's got to be down there. So if not us, who's next?
Well, I don't know who's next, but we're at the bottom of the hill because it's our own fault. I'm going to say some controversial stuff now. That's okay. You got me. I lose this. I lose this. We're at the bottom of the hill. It's our fault because we went to the priority on education like we should as an industry, right? Because the other folks that are at the top of the hill know what to say. They know the pretty words. They know how to put the pretty graphs together. They know how to host the pretty meetings, and they know how to get the meetings with the people that make the difference.
And they're working together.
Yes.
There's one nursing association.
Yeah.
There's 642 EMS associations.
But that comes from education. Understanding the importance of that comes from education. It really does. So education is number one. A desire for fire and EMS to come together as one and speak with one voice. Like, I get it. You know, I sometimes didn't like my sister. I used to take the big broccoli rubber bands and I'd shoot her in the thigh. But if anybody else, my sister, kicked her, I almost did it again. Right? And that's how we should be. Sure, you know what? Fire doesn't always get along internally, but we never see that on the outside. They keep all that stuff internal. Every other healthcare industry knows they can tear us apart by giving one or the other of us something. Right? We won't have it. But again, that comes from training and education. It really does. And speaking with one voice. Dude, I love the fact that you asked that question because I have questions about this. And I realize I'm Pollyanna here and I'm trying to pretend like there's an easy fix for it. There's not. Right? Those challenges run deep. But at some point, if we're tired of getting the crap, then we have to start slogging up that hill. We've got no other choice. And the first way to do that is to start showing up. At state EMS, at EMS on the Hill, and anytime that there's a message sent out, we need to work together in one voice. We agree on that voice, whether we absolutely 100% agree with it or not. We come to as close consensus as we can, and we do what we need to do, right? No one gets everything they want. Find the consensus and get some of what we want. Next question. What megatrends could make your business model obsolete? Who wants to talk? I'm gonna let anybody pick this one. What megatrends could make your business model obsolete? Tim?
AI.
Yeah? Yeah.
I mean, they're coming out with gizmos, gadgets, and widgets now that you can put on a pair of glasses. And those pairs of glasses will evaluate your patient along with you, will coach you. They'll also start filling out your EHR. And you know what? If you can put a set of glasses on just about anybody that takes care of a patient, then what's the value of EMS? What's the value of a paramedic?
Ambulances are gonna start driving themselves someday. I promise you that.
Well, the 2050 agenda for the future, when it came out, was like, what the hell is this? And now we're less than a couple of years away from it being accurate.
So anybody here ever read Anne McGonigal? She's a futurist. She predicts future trends. She's also a game theorist. Absolutely relevant to what we're talking about right now. phenomenal insight. And McGonigal. My favorite one is Reality's Broken. So very cool read. All right. So quantitative value, right? Now we have to quantify our value. So on the ambulance side, $402,000 in revenue over expenses year to date. And then in the MIH model, we have $822,000. So there's a difference of $419,000 between the two models. But the costs are lower. Now, again, the caveat to that is it includes grant funding and all the other revenues that come in. All right, utilitarian value. Now we're going to dig into it, right? Is this what you wanted, right, Dave?
Yeah, I want to go back to what Tim said about what mega trends, and this will bring up what we kind of been hitting on too. This whole conglomerate of these hospitals and stuff like that, that's going to do nothing, but it may not put us out of business, but it's definitely already affecting us, making us go farther, more time on task. We're worried about safety, and all of that is another thing that I think is a trend that is going to be something that we're going to have to deal with.
You know what I believe? Oh, sorry. So and I want you to make sure I get this right. So Dave, with Trinidad Ambulance states that this merger of hospital systems and larger and more powerful hospital systems, it's giving them more, and I'm paraphrasing here, more force to push us into doing what they want, and it takes away our autonomy because we can't, and ultimately end up having to bend to their will and do things. I think you're referring to things like transfers and be bullied around a little bit, right?
Well, it's pushing us farther down the road. And we're already at a point, whether it's staffing or other things that make our jobs more difficult. And by pushing those transporting our trucks farther down the road is obviously it's going to be a huge turn.
Yeah, so forcing our trucks to transport further down the road to the mothership is hurting our bottom line. And what I would say to that is they can only do that because we haven't unified yet.
Come back again. One thing that we see in the advocacy, talking about how many EMS agencies there are. I know there's some fire guys in the room, and I've done fire too, but we in Colorado can't even get on the same freaking boat between fire and EMS half the time.
Yep. And that's why they can divide and conquer us. Once that stops, once we see the value of getting some of what we want and not all of what we want, and we speak with one voice, then it'll be different. Until then, until we set education paramount, like the healthcare system, like the rest of the healthcare system does, and until we make data the Bible, until those things happen, everything you're talking about will continue to happen. We'll have micro successes, but we won't have global success. So I'm glad you brought that up. 10 minutes. Got it. So the ED avoidance downstream. So these are relative dollars. Every community is different. And a lot of this comes from the work that Eagle County, Delta County, and UPRAD have done together. Again, Aaron and, oh my goodness, Ruben and don't tell me, Alice. Sorry, she's amazing, by the way. Alice is a data guru, amazing person. If you haven't had a chance to learn from her, please do. Same with Aaron. But if you try to steal her, I'll stab you. But we know that an average of $1,200 in downstream costs every time we avoid an ED admission. It could be as low as $500. It could be as high as $2,300 or more, right? But the average is about $1,200. And if we've diverted 600, and this is just rough, if we diverted 600 patients away from the ER this year, then we've saved downstream $720,000 in that alone. minimum, and that doesn't even include the not billing for ambulance transport that we don't get paid for because we didn't transport them by ambulance, right? And then intentional self-harm or suicide. These numbers are brand new, hot off the presses. So the CDC's last time they looked at these numbers, they separated intentional self-harm and suicide as two separate things. And every completed intentional self-harm event where there wasn't a death was like $56,000. And every completed suicide had $1.6 million in GDP costs. The latest numbers, 2024 numbers, I think it was from March of 2024, but don't quote me on that. I do have it. If somebody really wants to know, I have it and I'll share the information with you. But they combined intentional self-harm and suicide. I actually don't know why they did that. I have suspicions, but I don't know why. Remember, there's lies, damn lies, and statistics, right? So every completed, so $709,000 for every intentional self-harm or completed suicide and downstream costs. So every time for Grand County, every time somebody completes suicide in your community, there is a cost, a GDP cost of $709,000 on average. So the cost of investigation, lost wages, lost performance from family members, all of your costs, healthcare costs, all of that. So if you prevent 2 intentional self-harm events or 2 completed suicides, you're looking just in that action alone, $1.4 million in cost savings to GDP. Now that's not directly to your community, right? And that's not real money, let's be honest. But it's a quantifiable way to show value for your services. And then the force multiplier effect. I got this number from a site and I'll share it with you. It's I believe it's National Fire Academy, but don't quote me on that. The average response cost for a fire engine to a single call is $111. For my fire guys, does that seem high, low, about right? Yeah, low. I bet you it's a little low, and I'm okay with going low over high because I want to be somewhat intellectually honest where I can be. So that means if we don't send a fire engine to every single, if it's a behavioral health call or it's a alpha or Charlie level call, we'll go ahead and cancel the engine. We'll give them the option of canceling, and most of the time they do. We want to keep them in service. We want to keep them available, right? Plus, we know, especially on behavioral health, if we can reduce the total number of people on scene, we turn down the temperature. It gives us an opportunity to come alongside the patient, come alongside the client, and create an environment of actively listening and collaborative partnership. Does that make sense? And that's $66,000 in downstream cost savings. Law enforcement officer. And this is on the very, very low end of that. I was surprised, like $1,300 is like property crime. And then it goes up as high as like $5,600 for felony bodily injury. So I went with the lesser of two evils. And assuming that we reduced their response 300 times, and really it would truly be probably half that cost, because we still have a law enforcement officer show up with us on all of our behavioral health calls, but we don't have 2 or 3 law enforcement officers show up with us on every behavioral health call. Does that make sense? So, but just at these numbers, we're estimating $390,000 in downstream cost savings. So our quantifiable value out of our utilitarian value is $2.594 million. Yes.
That's those 3 agencies come together.
What do you mean Oh, no, sorry. The only thing that was here, let me go back.
So that was just UPass.
No,
I think in general campaign.
so the downstream cost savings or ED avoidance, that is the only one that we share data on. This just came from our agency alone in the number of diversions from downstream cost savings for force multiplier effect. And what I didn't include in here is our own internal intrinsic force multiplier effect, right? the value of us not sending an ambulance to every single call. That hasn't been captured.
Part of the reason for my question is, if I look at CSFD and you guys have your volume of numbers, your volume is considerably higher than their volume. And so the numbers then begin to get.
Their CMed program is saving.
And so you've got to have that kind of data, right?
Oh, yeah, the best thing we ever did was showing PD how much money they would save.
And then they got on board.
So where did the 600 number there come from? Is that a UPass number?
Yeah, that's just our average number of calls where we can divert patients away from ambulance transport to the hospital.
Annually?
Average, yes. Yeah. So, and actually, I think we're getting close to 700.
We're at 720 right now.
Oh, so throw those numbers out. Apparently, we're so much higher. And this year, it's crazy that it's 720 because this year we've had to suspend our home program, which is our treatment in place program for everything other than behavioral health. So we no longer do our in-home urgent care program right now because we haven't had the funding to keep that program alive, and we lost our telehealth partner. You know, we are bringing some new telehealth partners on board. We're actually coming with some new creative local solutions for telehealth. So those will be coming on board soon. We also, I'm happy to share, we hired our very own, we got a grant from our ACO to hire our very own nurse practitioner. So we actually have a psychiatric nurse practitioner that's part of our team now. She's a full-time, she's not our employee. We've contracted with Washington Behavioral Health, but she wears our uniform, she drives our vehicles, she works with our staff. So for all intents, 5 minutes, got it. I love the fact, I hope I don't get through the slides because that means we've had an amazing and engaging conversation. So, and then additional non-quantifiable utilitarian value. So, geriatrics, remember we talked about loneliness and isolation. Geriatrics, the value to the geriatric population and to those who serve the geriatric population. Complicated medical clients, homebound patients. We talked about behavioral health, the medically fragile population. What other groups am I missing? What other groups can you add utilitarian value to in your community? I didn't catch your name in a green sweater.
Carry on.
Carrie Ann, what are some groups in your community that you think you could add utilitarian value to? That might not be addressed here, might not be. You're in Grand County, is that correct?
Yuma,
Yuma?
no, geriatrics and PR.
Yeah. So one of the populations that I think about in Grand County, and I only know this because actually so we make all of our providers get board certified in community paramedicine, which means they have to do 520 hours of didactic training through an accredited college or university. And part of that is they have to do a capstone at the end. And that capstone project is they get assigned a county that they've never, ever really had any contact with. And they have to do a community needs assessment in that county and develop a potential community paramedic program to identify a winnable battle in their community. And somebody got Grand County, and I remember it was a phenomenal piece of, I can't remember, it's probably 8 years ago now. But your winter employment population, your transient employment population. And I know you're in Yuma, but I'm talking about just Grand County because somebody did that assessment, and they found that population is underserved at an incredible level. Does that feel accurate for you guys?
It probably is. I would love to see that report. The Altera has put a tremendous amount of investment into addressing some of those issues.
Yeah, this, like I said, this was 8 to 10 years ago. So,
But they also just opened a massive employee housing facility that is, based on my experience in Summit County, going to bring a whole new set of issues.
so more to come.
Yeah.
All right. So total value. we take the quantifiable value and the utilitarian value, right? Quantifiable value plus utilitarian value equals total value, and the total value of the program becomes $3 million. We'll skip these. So now total value minus the cost, right, gives us a residual value, and that's 1.988 million. So, and just remember that 1.988 million and the rest of the equations we went through. I have 3 questions for you here at the end, okay? But opportunity cost. So the opportunity costs, again, what are the costs of going with this program over any other option, right? So obviously, we'd have increased ambulance response, increased police and fire response, rising rates of completed suicide, downstream costs associated with it, failure to meet community expectations. That's the big one, isn't it? That's the one that gets us fired, isn't it? Failure to meet community expectations. Yes, sir.
What I'm discovering more and more is reduction in profit response.
Speak on that.
Well, I mean, you know, we. Kim saying I have to come in front.
Yeah.
You know, we have sort of always hung our hat on this idea that we're making things better, but we're failing to understand that we're operating in a system that is driven by profit. And so if we're making things better, we're also reducing the overall cost of care. And by reducing the overall cost of care, we're reducing the profit associated with care. And so for good actors, which most people are, they say, yay, patients are better and we'll figure out how to do this. But there is a subset of the industry that sees the reduction in profit as a tension in the other direction. So it is an opportunity cost that we don't necessarily bear, but it is downstream and it can affect the political conversation. So we're trying to get these things move forward.
Palaces cost money.
That's the end of my thought.
Oh, thank you. I think that's it. And we discussed that a little bit in the beginning, but I think you wrapped it up with a pretty bow. So thank you very much, because that is true, right? If it is, in some cases, it's a zero-sum game. But our goal is to help them see that it's not absolutely a zero-sum game and find the opportunities for the win-win. But also, when it is a zero-sum game and there has to be a winner or a loser, make sure that we're speaking with one voice, because there's more of us than there is of anybody else. There really is. There is more of us than there is anybody else. And if we could harness that voice and unify that voice, we could literally change the world. And I believe that. All right, so is the VOA positive? Do you guys remember? Yeah, it was a positive number, right? Is the residual value a positive value?
Yes.
Yeah. And then is X real cost less than the alternative cost of another option?
Yeah.
So yes, yes, and yes. If the answer is yes to all 3 of those, then we are the value option. That option is the value option in the community. Does that make sense? And if you can make that argument, don't use that equation. I mean, you can use that equation internally to help you develop your argument, but if you can make that picture in your community, I think you can make a difference. Guys, I'm really sorry. I am out of time. But these are the funding opportunities, opioid settlement funds, and these are the community partners that you can actually go to, share your story, and show your value option, and bring your community partners with you. So, opioid settlement funds, ACOs, they used to be called the RICOs. Our ACO for this region is CCHA. If you live west of the mountain, if you live south, then it's probably Rocky Mountain. And then for everyone else, let me just skip to that. That's the opioid abatement regions. So for everyone else, so Kim, for your area, you guys are Region 2, you probably know that. You're Northeast Healthcare. And then for that little itty bitty part in the middle, that's Colorado Access. So The Bajasos, this is just, again, they matched, the ACOs now match the Bajasos, which is nice. One thing I am a little bit concerned about is they just announced the new Bajasos, and our Bajaso did not get the contract. So we're gonna be working with Signal Health. But I hear Signal Behavioral Health is a good partner. Like I said, for most of the state, you're gonna be working with Rocky Mountain Health. Rocky Mountain Health got both the ACO and the RICO for Region 1. These guys manage all the the ACOs manage all the Medicaid money for the general Medicaid or first choice population, Medicaid fee for service. And they get incentives, they get rewards for meeting certain accomplishments and improving overall health. These guys manage all the behavioral health money as it relates to Colorado Crisis Services. So you can reach out to them, tell your story. They have the responsibility to make sure that their crisis services obligations are met. Hospital transformational program, that's just a pot of money that gets siphoned off from the hospitals. It's 2% of their payments. It gets mixed with an additional 2.4 billion, so it gives you 3.3 billion. A lot of it goes to HIGPUF to do all kinds of special projects that HIGPUF does. And then about 300 million of it goes to the hospital transformational program. And the idea is that hospitals are supposed to work with community partners to address disparities in critical access areas. So if you have a critical access hospital, that 300 million goes to that. The 900 million supplemental payments, just like our supplemental payment program, to offset the cost of providing care to Medicaid populations. So that 300 million, if you have a critical access hospital in your community and you are the value option in providing a program or a service, they should absolutely be working with you, because the idea is not for all that money to stay internal at the hospital, but that's what's happening.
So the hospital should be working with you, but do they even know?
Oh yeah, they know what they're doing.
No, I'm talking about the critical access out in Yuma.
Yeah.
Do they even know this?
Oh yeah, they're getting the hospital. Not every hospital got hospital transformational money because they had to do community needs assessments, and they should have involved all their community partners, and they were really good about involving their partners in the community needs assessments. And then all of a sudden, all the solutions became internal solutions, and that was never how that money was meant to be spent. It was actually meant to be spent by working with community partners and providing some of that funding to community partners. So I bring that up in this way. They are forcing us to do transports from these critical access hospitals to the mothership, and we are supplementing their business model with these transports at often taxpayer expense. Hospital transformational money would be a great way to address that.
Is there some place that person could go find out which hospitals got those funds and how much funding?
Yeah, absolutely. Let me go back. I think I put that in there. I did not. So you can actually go to, you can just Google Colorado HTP or Colorado Hospital Transformational Program. It's got more information than you'll ever need. Plus, each hospital system that did it, they have to post their community needs assessment and how they're spending the money. So you can actually go to that hospital's website and see if they got money and how they actually addressed it. It probably won't be 1 or 2 clicks in, would be my guess. You might have to do a little bit of data mining. And then don't forget Colorado foundations. And I just listed a bunch of foundations here. There's more, but these are ones that we've had great success with. Not all of them, but most of them. And then I want you to think about one other thing: tax revenue. Local tax revenue is a great way to supplant federal regulatory oversight in a lot of ways, because we're forced to take a lot of federal money, and we're beholden to the federal government in a lot of different ways, right? Through CMS, anytime we take a federal grant. And so anytime we can increase our operational budget locally, that decreases our dependence on the federal government, and it allows us to be more subservient to our constituents. So when you think about going for a sales tax, that is a great way to market it. We don't want the federal government to tell you how your healthcare needs to be provided any more than we're absolutely required to. And by taking more local tax money, you get to have greater say in what your ambulance looks like. And the federal government, because we could tell CMS to piss off if we wanted to, right? If we had enough money, we could say, we're gonna do what we want because we don't need your money. We don't need to bend to your will. Now, maybe we don't do that, but we could. We could. That gives us a lot more freedom, doesn't it? So just a thought.